Hello, and thanks so much for joining us. I'm Carol Jenkins. The program is Black America. Now, we know that recent decisions being made in Washington are bringing a great deal of uncertainty to organizations that serve marginalized communities. My guest today is Dr. Melicia Whitt-Glover. She's the president and CEO of the Gramercy Research Group and also CEO of the Council on Black Health, a research and action network that provides thought leadership to develop and implement a national agenda for Black health. Thank you so much for being with us today.
Thank you for having me.
It certainly is a topic that needs to be discussed because we are in the middle of what feels like a collapse of the institutions that we generally count on to make us healthy, even though they don't, even though we've had these medical issues always, it seems. How do you phrase where we are now in terms of your organization and what's happening in the medical world?
We're in an interesting time where things are collapsing, and now is an opportunity for us to figure out how we can move forward, how we can work together to be able to continue to do the great work that's been happening to improve health, and an opportunity to maybe think about doing some things differently.
Right, so as we record this, you know, you're experiencing in your organization the pulling back of funding for the research and community work that you do, as are many of your colleagues. How do we address that? I mean, is anybody in Washington listening?
I am not sure if anybody in Washington is listening, because I think right now things are in such chaos that people are still trying to figure out what is going on. There were people that were showing up to work and they were finding out that they didn't have jobs that day. So I don't know if people in Washington are listening, but what I do know is that people on the ground in communities are we're going to have to pull together to solve this crisis.
Yeah, I think this is on us, right? We have to replace that, whatever federal, and now that affects state funding or city funding, the trickle-down effect in that really serious regard has to be replaced somehow with philanthropic funds?
Absolutely, philanthropic funds. And I know that a lot of organizations now are turning to philanthropic funds, to philanthropy, to try to get funding to fill in some of the gaps. And so we're doing those same kinds of things.
Well, you know, speaking of health-wise, is that I guess the figure higher than it's ever been is that 11% of people who were interviewed said that they could not afford to go to the doctor, or if anything happened to them seriously, they would be in bankruptcy. Does that affect us more so than the general population?
I think it does because of historical and systemic racism. There's always been differences in terms of the amount of income that people get. And so when you look at for every $1, say a male earns, women earn less. For every dollar that a white person earns, Black people earn less. And so when you think about that, there has always been limited funding. Prices continue to go up, but if you think about things like the minimum wage, that has not changed in years, but costs of things continue to go up. And so as we continue to not have access to health care, people get sicker, they're diagnosed at later stages, that's more expensive to treat. And so then it's more costly.
So it's a continuation. When I was coming here, a friend called me on the phone, and she was just getting ready to go to her cardiologist. She said, and the reason that I switched was that the other one just wasn't into me, wasn't nice. You know, I didn't feel that I was being cared for. And we hear this from many, many Black patients who feel that they don't get respect in the doctor's office.
We do. We've done some work just talking to people who were dealing with cancer in North Carolina. We did some interviews with folks, and I heard a story of a woman. It was really compelling. She was a woman. She was obese, and she kept going to her doctor because she was having stomach pain. And they kept telling her that she just needed to lose weight. And it wasn't until she went to the emergency room because she was throwing up black bile that they finally diagnosed her with later stage cancer, stomach cancer. But she was dismissed every time she went to the doctor to say something's not right, something's not right. They dismissed her and said, you just need to lose weight. And so those are the kinds of things that continue to happen even today.
So you mentioned obesity, and you have done research in that and are continuing to, to do it. I was surprised to look at the figure. It's almost 60% of Black women who could be placed in the obese category. Explain what that means, actually.
By the body mass index standards, more than, yeah, so there's a high proportion of Black women, but really people in the United States that are overweight or obese. And so that leads to additional complications that are related to things like joint pain, other chronic development of other chronic diseases like hypertension, heart disease. And so it exacerbates other issues.
So, so working with women who are obese, and again, so all Americans, as you say,
Yeah.
we're all sort of topping out more, and it adds to the unhealthy aspects and projections that many of us have in our lives. But why are we obese?
So there are lots of things that I spend probably more time than I need to on social media. But one of the things that I've seen many times come across my page recently is the ingredients that are in I think it's one of the cereals, the ingredients for what's sold in the United States compared to what's sold outside the United States. We have so many things that are added to our food, so much corn syrup, so many just extra things that we don't need in our food that's leading to excess weight. Cortisol, which is a hormone that happens when that's caused by a lot of stress. Those are the kinds of things that put weight on our bodies, and so we don't have access to a lot of healthy foods. We don't have a lot of time to cook fresh foods because we're working all the time, and so those are the kinds of things that lead us to having more weight than we need to have on our bodies.
So in addition to being in that high category for obesity, for hypertension related, I'm sure, to the obesity, talk to us about that and the work you're doing in Cincinnati.
So hypertension is related to obesity as well. So we're working with a group called the Center for Closing the Health Gap in Cincinnati. They are a community-based organization that's been around for a number of years. They've received some funding from their county government to work with several hospitals in the community to try to figure out what kind of intervention they can do at the community level to be able to address hypertension control for Black women. The Council on Black Health is working with that group to be able to come up with an action plan. So we really want to focus on not trying to fix people. So there's nothing wrong with you, there's nothing wrong with me, but the systems that we live in make it very difficult for people to make healthy choices. And so we'll be working with them to look at the intervention, but also say, what are all the systems that could support people that need to come into play, policy, systems, environments, so that when people go to make healthy choices around hypertension control, they can do that easily.
So according to the American Heart Association, hypertension in the United States is just off the charts. And in fact, for Black women, 58% have hypertension as opposed to only 43% for white women.
One of the things with hypertension, though, is it doesn't happen overnight. You're not normotensive one day and then hypertensive the next day. And so we have clues along the way. So it's important for us to pay attention to our own numbers and know what our blood pressure is all the time. Because a lot of times when you go to the doctor, if your blood pressure is normal, they'll say it's fine. They won't necessarily let you know that it's creeping up. And so it's better if we can make sure that we're doing things like exercising, eating right, identifying ways to reduce stress so that our blood pressure stays under control for as long as possible.
So when we talk about the determinants of health, there are things like wealth, academic levels, although we know that, for instance, in Black maternal health, it makes no difference how smart you are or how rich you are. If you're a Black woman, you stand a huge increase in a probability of some issue, a problem or death of mother and baby. There's the environment. So what's going on when your home is toxic, your neighborhood? I mean, these are things that will show up could show up later in life as opposed to, but you've been exposed when you're a child.
They could show up later in life. And those are the kinds of things that disproportionately in communities that are concentrated, where we have a concentrated number of residents of color, those kinds of things like environmental pollutants, lack of access to fresh fruits and vegetables, those kinds of things are more concentrated in communities where you have higher proportions of people of color. And so then that just continues to make the problems grow. But even when, as you mentioned, even when you have wealth, even when you have income, the challenge is when you walk into spaces where you're getting service or where you're getting health care, nobody asks you for your tax records or your diploma. They look at you and they make decisions, and that's how you're treated.
Right. We were talking a little bit before we started recording about the absence of black doctors, because what we tend to think that, oh, if the doctors were black, then we would be treated well. But there are so few. Mm-hmm. I interviewed the New York State Health Commissioner recently, and they even have to have a program to try to bring more doctors in, because it's like infinitesimal, just the sheer number of black doctors that exist.
Yeah. We were talking about that earlier, and one of the challenges is there's a small pool of people. By the time you're trying to recruit people to become doctors to go into medical school, the pool is small. The council has done some work with an organization called the National Black Child Development Institute. They did a report several years ago that showed that in early childhood education, so preschool, Black and brown children are, I think the statistic was 5 to 8 times more likely to be suspended or expelled at preschool. So if you think about, you don't just get to high school or college and then
you don't get to first grade.
Right, you don't get the first grade. You don't get the early education. So then we're losing kids along the way. And then we have this small pool, and we try to get them all to go into healthcare. But then you've got people that are trying to get that small pool to go into engineering. And so we've got to look at the whole entire education pipeline if we're trying to increase the number of children that are black children that are going into medical fields.
So you are now working in that front and others with partners. Talk to us about some of I know there's the Bill of Rights too, that, let's go through. I was watching one of your videos, and the key thing is, listen, when we walk into a doctor's office, we should be respected, and our own sense of what's happening to our bodies needs to be respected.
So respectful and dignified healthcare, to go back to your example of your friend that is going to the cardiologist, that's one of the keys. So you've got to have a relationship with the person that's providing your healthcare. They need to know you, so that and you need to be comfortable with them, so that you're able to exchange. It's an exchange of information. You, as a patient, are the best advocate for your health, and you know yourself the best, but you've got to be able to have that relationship with the person that's providing care, and that person has to respect that you have that knowledge. A lot of times those relationships and those exchanges with care providers are very much top down. I know what's best for you. So that respectful and dignified healthcare is critical.
Does it fit just generally in systemic racism that there seems to be a cluelessness, a cultural cluelessness in a sense for black patients?
So lived experience can really help shed a lot of light on how you come up with solutions for things. And so without having differences in thought in your medical school classes, in your training classes, and with the people you work with, you tend to have very siloed ways of doing things. And so some of it is racism, some of it is lack of exposure to any other groups that are different from you, and so it could be cultural ignorance, but I think it's really a combination.
What's its effect?
I will say, so the Council on Black Health is made up of a combination of a group of academic researchers, people from communities, community organizations, and I want to say it was our 2019 conference, we were talking about what we needed to do to improve health in Black communities. And I remember our founder, Dr. Shariki Kumanika, she asked us an important question: do we think that Black people can be healthy? And if so, what are we going to do about it? And one of the participants said, we need a Black Health Bill of Rights. And so collectively, that group of 150 people or so came up with the articles in the Black Health Bill of Rights. I think the effect, we released it in 2021, and it's growing in popularity in terms of, I won't say popularity, recognition of people really looking at that and saying, yes, this is something that we should be striving for. So it's what drives the work of the council.
And the other work that you're doing, I know, again, on the day that we're recording, we're listening to all kinds of reports about funding being retracted, but tell us about some of your partnerships that you hope will continue under some way or another.
So I mentioned the work in Cincinnati. We're also doing a really unique project called, it's a Trusted Health Navigator training. It's part workforce development and part helping to address some systemic issues, where we are working with people who live in communities, particularly low-income communities, and they're getting training. So it's about 180 hours of training to be community health workers. And they are able to then partner with hospitals or healthcare organizations to bring needed resources and information back to their communities. And so in Chicago, we're working with Humana. They are funding us to address some issues related to social isolation by training people from low-income communities to be able to be trusted health navigators. So we hope that continues.
Right, right. Well, I serve on the board of an international health organization in Africa. We've trained thousands of community health workers. I mean, it really is the the connection.
Yeah.
They serve as interpreters of the culture, as we were talking about before. So that is fantastic. I'm thrilled to know. And in terms of, there's this recent case where sickle cell, our family is affected by sickle cell trait disease. And so we're always acutely interested in developments. And apparently there has been a cure of the first declaration, but sickle cell, as well as other diseases that affect only what, as we're described as marginalized people, it rarely seems to get any attention.
And it's interesting because those kinds of things, we are acutely aware of what's going on. So within the Black community, we are all aware of sickle cell, but how to get that information out to other communities and folks that provide funding to make them care is something that we're going to have to continue to work collectively to raise awareness and to share information within our own communities about what's working, so that collectively we can help to be a part of the solution.
So again, the cuts where the idea, the mention of Medicaid, Social Security, things like that being cut. What happens then? What if Medicaid, which many people depend on, if that's cut, how are people going to be treated?
We can't let that happen because there are people that rely on Medicaid for their health care. We can't let that happen. And so we've got to do everything that we can to be able to advocate to ensure that the people that we've elected are advocating for our health. Because if Medicaid is cut, there are going to be a number of people who are going to suffer unnecessarily.
How do you raise the alarm for that? What can you tell us that's going on now in Washington as these things are being examined and looked at, and as they're looking for fraud, et cetera? How can we stop that?
So some of the things that we've been trying to do within the council are helping people to really understand civics and understand who makes decisions and how decisions are, so who within our communities, who within our elected officials are responsible for advocating for us. So we can certainly ensure that we can write letters, we can make telephone calls, we can ensure that we are electing the appropriate people to be able to make decisions. As a lot of this work has happened, we've been partnering with the NAACP. They've put out several guides, action guides that people can use to be able to take action. There are kits that folks can share within their communities on how to take action. So we've been doing some of that kind of work.
And I wanted to ask you before we end about mental health.
I will say one of the things that we have been working on that's related to mental health is the issue of social isolation. So we know that particularly starting with the pandemic, we have become more and more separate, and there's strength in communities. And just as an example, one of the projects that we did in Charlotte, North Carolina was we worked in 3 historically Black neighborhoods. And we partnered with them to be able to come up with action plans for how we could get people out of their houses and back in community, connecting and supporting one another. And so those communities now have been able to get community gardens, walking trails and things that get people in connection. And so when you do that and you realize that you're not alone, people realize that they're not alone, it can address some of the mental health issues.
Right. So you're starting your chapter outreach now. How do people get involved? How can they join up with you?
The best thing to do is to reach out. They can send an email to info@councilbh.org and reach out and let us know what it is you're interested in. I like to say that the council really wants to be additive and not duplicative. And we know in a lot of communities there are already people that are working. And what we want to do is to come in and provide support where we can to be able to help people not work in silos, organizations not work in silos. So in any community, there is almost always going to be groups of people that are working separately. We want to collectively work together to be able to share our resources. And right now, with resources being cut, that's going to be critical.
It will be. It will be. Yeah, you talked about reimagining health for Black America. Talk to us about that. What does the future look like?
What the future looks like, we've been asking people, what does reimagining health mean to them? Because certainly I don't want it to come out of my mind. And what people have defined as reimagined health is joy. It looks like having enough resources to be able to live comfortably with your family. It looks like being able to go outside and breathe and smile and be free. And it's interesting because what it doesn't look like is a BMI level that's at an acceptable. It doesn't look like a particular blood pressure level. And so we're really working with people to say, how can we come back and reclaim that joy? What does that entail? And that is working collectively, coming together as communities, supporting one another, and building new structures new structures and systems as these old ones are falling. But we can do it together.
And how did you come to this work? You know, you're a PhD, I can't even say that.
Epidemiology.
There we go.
Yeah.
You know, a fancy doctor. You know, a researcher. What was your path up?
So my path up, I started that I wanted to be a physician, but then I said, you know, I want to be able to help more than one person at a time, and that led me to public health. But really my passion has always been, since I was a little girl, has always been to try to help people, to do as much as I can to help as many people as I can. And I met Shariki Kumanyika at a conference, and what I was excited about with her was that she was actually developing and testing programs to help large groups of people. And it's just grown from there.
Right. And so to talk to us about systems-based change, what is that?
Systems-based change. And so if you think about the ways that we operate to be able to move through accessing healthcare or accessing of foods, we have to figure out how to make those processes work. And I'll just give you an example. The cancer work that I mentioned before, we talked to people about what would make it easier for you to navigate through this system to be able to access care in the cancer center. And surprisingly, it was very simple things like the signs it makes it very difficult for us to maneuver through the hospital, or the parking is so far away, but because we're coming in for treatment, we're unable to get there. So being able to work within that system to say, look, people are trying to access care. If you can fix and address the way that you are providing that care, you've now fixed this system so that you're able to provide the care and people are able to access it. So going into those kinds of infrastructures and being able to make tweaks so that it makes it easier for people to be able to do what they need to do to be healthy.
And how long have you been doing this now? I want to ask you about your level of optimism that we will be able to fix the condition of Black health in America.
So I've been in my role with the council since 2020. So I started during the pandemic, but I graduated in, I like to say, the late 1900s. So been at it for about 25 years professionally. I remain optimistic because the alternative is doom and gloom, and that's just, I can't do that. We've got to keep fighting until the very end.
Well,
I'm optimistic.
You're optimistic. Well, we're delighted that you're doing so much connecting and so much work to make this happen. We need our health, we need our rights, and we need to be able to feel comfortable when we walk into a doctor's office that they're actually going to listen to us.
Yes, and we need to be comfortable that if they don't, that we go find another doctor who will.
Exactly, exactly. Well, thank you so much, Dr. Melicia Whitt-Glover, CEO for the Council on Black Health. You can visit their website at councilbh.org for more information, or if you're interested in starting a chapter in your city, and especially to support what they're doing now, to make a contribution. Thank you so much, Doctor, for being with us.
Thank you.
And thanks to you all for spending time with us. That's it for us. I'm Carol Jenkins. The program is Black America, and we will see you the next time. And now you can download the CUNY TV app in your Apple Store or in Google Play and find us there.